I mean, I want you to imagine, just for a second, a scenario where the one thing you desperately need to get better, like the literal cure to your suffering, is physically guarded by your absolute worst fear.
Yeah, like if you were terrified of heights, the doctor's office is at the top of a swaying tightrope over a canyon.
Exactly. Or if you are terrified of spiders, the medicine is resting at the bottom of a terrarium full of tarantulas.
Oh, wow. That is a terrifying visual.
Right. But how do you get the help you need when the mere act of getting the help is the very thing that triggers your condition? So, welcome to the deep dive.
It is a profound paradox, really. The structure of the disease essentially acts as a moat, locking the patient away from the exact interventions designed to save them.
Yeah, and our mission for this deep dive is to examine a stack of notes on one of the most, well, probably the most misunderstood mental health paradoxes out there. And that is the treatment of agoraphobia.
And specifically, we are looking at how a telehealth practice in Georgia called Coping and Healing Counseling, or CHC, is using technology to completely bypass that moat.
Because we are really looking at a fundamental shift in the logistics of mental health care here.
Definitely. I mean, the big aha moment waiting for you in these sources is that technology in healthcare is not always just about modern convenience.
Right. It is not merely about, skipping the waiting room because you have a busy Tuesday.
Exactly. For some conditions, and particularly the one we are dissecting today, technology is the singular mechanism available to bypass the disease's natural defenses.
So let us unpack the condition itself. Because, agoraphobia is a term that gets thrown around a lot in pop culture and honestly, usually entirely incorrectly.
Oh, absolutely. People use it colloquially to mean like someone who just likes to stay home.
Right, or an extreme introvert who cancels plans. But looking at the clinical sources we have, the reality of the diagnosis is miles away from just a personality quirk.
Strictly speaking, agoraphobia is defined clinically by a marked intense fear or anxiety about two or more very specific types of situations.
And those environments are things like using public transportation. Right?
Yeah, public transit, being in open spaces like parking lots or bridges, being in enclosed spaces like shops or theaters, standing in line or being in a crowd, or simply being outside of the home alone.
The common thread there really seems to be a lack of immediate control. And I want to clarify the severity of what is happening in the body during those moments.
Because it is intense.
It really is. This
Yeah.
is not just feeling shy or preferring a quiet night in. It is like your brain's alarm system is fundamentally
Wow.
miscalibrated.
Yeah.
The fear you feel in a grocery store checkout line is entirely out of proportion to the actual danger. But your body does not know that.
No, it produces completely real, terrifying, panic-like symptoms.
Exactly. Your heart races, your vision tunnels, you feel like you cannot breathe, your chest tightens.
The physiological reaction is basically indistinguishable from the biological response you would have if you were being chased by a predator.
And the underlying logic of that fear is where the clinical criteria really illuminate the patient's internal experience, I think.
Yeah, this anxiety stems from a very specific, terrifying thought. The person fears that if these panic-like symptoms occur, escape might be physically difficult.
Or help might just be entirely unavailable.
Right. It is the terror of being trapped in your own uncontrollable physiological response without a safety net. So the fear is not necessarily of the grocery store itself.
It is the fear of having a medical or psychological emergency inside the grocery store and being unable to flee.
Exactly.
It is like the fear of the fear itself happening in a place where you are totally exposed.
And to meet the diagnosis, the significant avoidance and fear must persist for 6 or more months.
Wow, 6 months.
Yeah, and furthermore, the sources point out that agoraphobia frequently co-occurs with panic disorder.
Which makes sense, right?
Uh-huh.
When a patient is experiencing spontaneous recurring panic attacks, the agoraphobia develops as a secondary defense mechanism.
Exactly. They start avoiding any place where a previous panic attack happened, and the avoidance behavior just compounds.
Until it leaves people near or completely housebound, the physical world systematically shrinks.
It does.
It shrinks down to the size of your living room. Buses, crowded sidewalks, even just walking down your own driveway to get the mail. I mean, all of it feels like a life or death proposition.
Which brings us right back to that cruel catch-22 we opened with.
Right. The logical question becomes, how do you deliver care to someone who physically cannot leave their residence?
Because the very nature of the condition prevents engagement with traditional in-person clinical care. Walking into a busy waiting room, sitting in bumper-to-bumper traffic on the way to an appointment.
Or just being surrounded by strangers in a clinical setting?
Yeah, these scenarios map perfectly onto the exact targets of the phobia.
The isolation is just devastating because the anxiety that makes you need the help is the exact same anxiety preventing you from acquiring it.
You are locked out of the clinic by your own mind.
And this is where telehealth enters the picture.
Yeah.
And it serves not as a perk, but I mean, as a life-changing clinical necessity.
Telehealth fundamentally alters the treatment landscape for this condition. It means the initial therapeutic contact can begin from a bedroom, a couch, or just the one specific chair in the house that still feels safe to the patient.
Okay, wait. Let me play devil's advocate here and push back on this approach a little bit.
Sure, go for it.
If the entire pathology of agoraphobia is about avoiding the outside world, I mean, if their world has shrunk to the size of their couch, does not allowing them to do therapy from that same couch just enable the avoidance?
It is a common question.
Like, are we not just catering to the phobia by validating their decision to never leave the house?
Well, we have to examine the psychology of safety before any learning can actually occur. Think of it this way. You cannot teach someone the mechanics of swimming if they are currently actively drowning.
Oh, right. You were basically trying to teach backstroke in a hurricane.
Exactly. They are not listening to your instructions. They are just trying to find air.
That makes a lot of sense.
If you force an agoraphobic patient to drive to a physical clinic, their nervous system is entirely hijacked by panic long before they even sit down on the therapist's couch.
Right. Their brain is just flooded with cortisol and adrenaline.
And in that heightened state of sympathetic nervous system arousal, the fight or flight mode, the brain's prefrontal cortex, which is responsible for logic, reflection, and learning, is essentially offline.
They're just in pure survival mode at that point.
Yeah. So telehealth provides a secure baseline. By starting the session in a space they already perceive as safe, the patient's nervous system is calm enough to actually process the clinical work.
So we are not enabling the avoidance. We are just establishing the physiological baseline required for treatment to even begin.
Exactly. You have to bypass the alarm system so you can finally talk to the rational person trapped inside the house.
Okay, so once they are safely in that virtual room with the therapist, their heart rate is normal, they can focus.
Oh.
What does the actual heavy lifting of that treatment look like?
Well, our notes highlight that the gold standard, evidence-based treatment combines CBT, which is cognitive behavioral therapy, paired with gradual in vivo exposure.
And it mentions SSRIs, right? A type of antidepressant medication.
Yeah, those may be prescribed by a licensed clinician when appropriate.
Let us break down the mechanics of those interventions, maybe starting with the medication. I assume SSRIs do not magically erase fear.
No, they do not. What they do is modulate the chemical baseline of the brain. Serotonin plays a key role in regulating the amygdala.
Which is the brain's threat detection center.
Exactly. And in someone with severe agoraphobia and panic disorder, that threat detection center is hyperactive. So by stabilizing serotonin levels, SSRIs essentially turn down the volume on the background panic.
They lower the baseline physiological noise so that the patient has enough emotional bandwidth to engage in the heavy lifting of therapy.
Right. The medication gives them a bit of breathing room so the therapy can actually take root.
And that therapy is CBT. Sifting through the clinical definition, CBT is not just, talking about your feelings. It is highly structured.
Very much so. It is about dismantling distorted thoughts.
So if the agoraphobic thought is, well, if I walk to the mailbox, I will have a heart attack and die, the therapist does not just say, no, you will not.
Right. They systematically dismantle the architecture of that belief. The therapist employs Socratic questioning.
Like what?
They might ask, what is the concrete evidence that you will have a heart attack? Have you walked to the mailbox before?
Right.
What happened then? What are the alternative explanations for your chest feeling tight?
So the patient learns to recognize that a tight chest is a symptom of anxiety, not actual cardiac arrest.
Yes. But cognitive restructuring alone is not enough to rewire the brain.
That is where the in vivo exposure comes in.
Exactly. It is the critical catalyst. In vivo translates to in real life. It involves physically facing the feared situations systematically.
And this is the part of the source material that completely changed how I view telehealth.
It is pretty incredible.
It really is. Telehealth uniquely supports gradual in vivo exposure in a way that a traditional brick-and-mortar clinic structurally cannot.
Yeah, because if you are receiving traditional therapy, exposure is a massive, overwhelming, blunt force leap.
Right. To get to the clinic, you have to leave the house, get in the car, drive in traffic, park, and walk into a waiting room.
It is a massive, uncontrollable spike in exposure all at once.
But with a smartphone or laptop, The steps can be incredibly granular.
The level of control the therapist and patient can wield over the exposure environment is just revolutionary. Because the therapist is communicating through a screen, they can virtually accompany the client as they execute these micro-exposures.
I mean, imagine a patient who has not left their living room in a year. During a virtual session, the exposure exercise for that day might simply be standing up, walking to the front door, and resting their hand on the doorknob.
Yeah, and we really have to picture this scenario vividly. The patient is standing at their front door, physically shaking.
Their heart rate is spiking because they're touching the boundary of their phobia.
But they are holding their phone in their other hand, and their therapist is right there on the video call, observing their breathing, providing real-time anchoring.
Saying things like, I am right here with you. Notice your heart rate. Tell me what your chest feels like right now.
Yeah, wait for the panic to peak and watch it subside. The therapist is acting as a real-time anchor to reality.
So the brain experiences the panic, realizes no actual harm occurred, and the threat response downgrades.
Exactly. And then the following week, the micro-exposure might be turning the doorknob and looking outside for 30 seconds.
And the week after that, stepping onto the porch.
Telehealth turns what feels like an unscalable vertical cliff into a ramp constructed of 2-inch steps.
It delivers face-to-face clinical support during the exact moment of exposure, without forcing the massive triggering event of a commute.
It really transforms the smartphone into a clinical lifeline.
Okay, so having established the mechanics of how brilliantly this works in theory, the notes pivot to the practical reality. Because, I mean, a theoretically perfect treatment model is totally useless if people cannot access it.
Right. How does this highly specialized care actually deploy in the real world?
Which brings us to the specific operational model of coping and healing counseling, or CHC.
CHC really functions as the real-world proof of concept for this entire approach. They operate as a 100% telehealth, HIPAA-compliant practice based in Georgia.
And the most crucial operational detail is their geographic reach. I mean, they are licensed and equipped to serve all 159 counties in the state.
That geographic detail is massive. Georgia has such a stark contrast between its dense urban centers like downtown Atlanta and its sprawling, highly rural southern and Appalachian counties.
Yeah, if you live in a rural county, the nearest physical clinic specializing in severe anxiety disorders might be a 2-hour drive away.
And for an agoraphobic patient, a 2-hour drive might as well be a trip to the moon.
Exactly. By operating entirely via telehealth, the geographical barrier is instantly vaporized. The specialist just comes to you.
But the infrastructure supporting that reach requires a specific kind of clinical depth. The sources detail a culturally competent team of over 15 licensed therapists.
Yeah, this includes licensed clinical social workers, licensed professional counselors, and licensed marriage and family therapists.
And the actual diagnostic work is conducted strictly by licensed clinicians. Cultural competency is vital here, too, because building rapport with someone who is profoundly isolated requires deep trust.
Right. If the patient feels misunderstood by the person on the screen, the therapeutic alliance just fails.
Precisely. And the scope of their practice is very broad. They treat individuals, couples, families, and teens ages 13 and up.
Plus life coaching.
Right.
Addressing everything from trauma and PTSD to grief, relationships, and depression. But the detail in these sources that I found most compelling is not even the clinical scope.
Oh, what stood out to you?
The financial architecture. When we talk about barriers to care for agoraphobia, the financial barrier is often the final, insurmountable wall.
Oh, definitely. The correlation between severe agoraphobia and poverty is a harsh reality. If your world has shrunk to the size of your living room, maintaining traditional employment becomes nearly impossible.
And the loss of income directly restricts access to specialized private health care.
Which is exactly why the insurance details provided here elevate CHC from a convenient service to a systemic solution.
Get this. For Medicaid patients, there is a $0 copay. Zero.
That is incredible.
For a disease that actively strips people of their ability to earn a living, removing the out-of-pocket cost is a genuine medical necessity.
And for those with major private insurers, the list includes Aetna, Cigna, Blue Cross Blue Shield, United Healthcare, and Humana.
Yeah, for those patients, the sessions typically range between just $10 and $40.
The operational model aligns perfectly with the clinical mandate. They have dismantled the geographic boundaries by covering all 159 counties.
They have dismantled the physical barriers by utilizing a pure telehealth model.
And they have dismantled the socioeconomic barriers through broad insurance acceptance and $0 Medicaid copays.
It is amazing. Coping and healing counseling is systematically dismantling the exact infrastructure that agoraphobia relies on to isolate the patient.
They're essentially handing people a sledgehammer to break out of a room that has been shrinking for years.
And the logistics are fully available for anyone in Georgia who needs to explore this kind of intervention. Their contact information is detailed in our show notes.
Yeah, their website is cheektherapy.com, and you can reach their support team directly via the phone or email listed there.
Their number is 404-832-0102. And the email is support@cheektherapy.com. It is just so rare to see a clinical theory map so perfectly onto a real-world business model.
It really serves as a blueprint for the future of behavioral health. It proves that modern mental health care must adapt to the actual lived pathology of the patient.
Rather than demanding the patient adapt to the rigid traditions of the clinic.
Exactly.
So, to bring all of these threads together, we have looked at the intensely debilitating nature of agoraphobia.
We understand how the fear of a panic attack builds a fortress around a person, locking them out of traditional help.
But we have also seen how technology, specifically the telehealth model utilized by practices like CHC, acts as a brilliant Trojan horse.
It sneaks evidence-based treatments like CBT and meticulously controlled in vivo exposure right past the brain's miscalibrated alarm system.
Delivering life-saving care directly into the patient's safe space.
The broader paradigm shift for you as a listener is really a lesson in lateral problem solving.
Yeah, when you're faced with a seemingly impossible obstacle, whether in healthcare, business, or just your personal life.
Relentlessly battering against a heavily guarded front door is often the wrong strategy. Finding a completely different method of entry, bypassing the defense mechanism entirely, is where true innovation happens.
And telehealth is that alternative entry point. It redefines the rules of engagement completely.
It really does.
As we wrap up this deep dive, I want to leave you with a final thought to mull over, which is a natural extension of the mechanics we have explored today.
Oh, where are we going with this?
Well, think about it. If telehealth currently allows a therapist to safely guide a housebound patient through real-world exposure via a glowing rectangle on their smartphone,
Right.
how long will it be until psychiatric therapies fully integrate virtual reality?
Oh, wow.
Imagine that same patient putting on a VR headset and practicing walking through a hyper-realistic, crowded grocery store,
Experiencing the spatial audio, the visual clutter.
all while having their therapist in their ear monitoring their biometric data, all from the absolute safety of their living room couch.
That is just wild to think about.
If the cure you need is guarded by your worst fear, the future of medicine might just be learning how to safely simulate the monster until it simply is not scary anymore.